Good afternoon, everybody. My name's Martin Carby. I'm a chest physician at Harefield Hospital in London. Thanks for asking me to speak with you this afternoon. Theracos have asked me to speak about the patient journey in lung transplantation and a little bit about where ECP plays a role in that. And my contact details are on screen if any of you want any more details afterwards. And I'm grateful to Theracos for their sponsorship. So lung transplants are excellent treatment when patients have end-stage lung disease and there's no other medical therapy, and they offer an improved quality of life and increased survival. And the centre that I work at Harefield does a reasonable volume of transplants, a few more than other centres in the UK. But of course, it's not perfect treatment, and the 5-year survival after a lung transplant is about 65%. So it is not a cure for bad lung disease, but it offers an improved quality of life and an increased survival for appropriate patients. And those patients are people with advanced lung disease and severe symptoms. I put those two things separately because if a patient has bad lung disease but they're coping, then the risks of a lung transplant can be completely unjustified. So advanced lung disease, severe symptoms that are getting worse despite the best medical therapy. And there are criteria, international criteria and UK based recommendations that mirror the international criteria for patients that are suitable to undergo treatment with a lung transplant. But then there are a number of factors in those guidelines that do preclude some patients. Some of them are obvious. If you've got bad heart disease or bad kidney disease or any other severe illness, then just replacing the lungs obviously isn't going to make that better. But some of the more subtle things that we focus on are physical frailty, and my next slide deals with that. Physical maintained, some degree of maintained exercise capacity as a sign of rehabilitation potential after surgery. People need to be physically and emotionally incredibly resilient to get through this difficult treatment. And at some point, we also have to draw a line and say that some people are just too sick to undergo lung transplants. And one of the things that we focus on to try and get as many people through transplants as possible is preoperative rehabilitation. People become physically deconditioned because of breathlessness, which must be deeply miserable to experience. Then they get intercurrent exacerbations, have drug treatments like steroids, which cause muscle wasting, and all of those things impact muscle strength, which exercise can to some extent reverse. And the stronger people are going into a lung transplant, the easier it is for them to come out the other side. And we optimize survival, reduce hospital stay, and reduce complications. And use a 6-minute walk test as quite a useful measure of both how urgent it is to try and get somebody through a lung transplant, and to decide when it might have become too late. So when the surgeons have done their job, this is when the physician team swings in, and we trying to deal with the complications, which I've divided into early and late complications. The most prevalent thing that happens early is infections, mostly in the lungs, and we spend a lot of time dealing with infections, which can be bacterial, viral, fungal, and mycobacterial. Acute rejection, everybody worries about all the time, but we can identify that, and that's largely a steroid responsive problem. So although we need to be vigilant about it and treat it, it's not a huge problem. Then there are other complications of surgery: the bleeding, air leak from where the airways have been stitched together. Primary graft dysfunction is new lungs don't work and we don't know why. And the care is supportive. Diaphragmatic weakness can be caused by impingement on the phrenic nerves during surgery, and obviously, as well as a lung having an air supply and circulation, it needs a pump to get air in and out of it. And if the diaphragm doesn't work, that's a big problem. But so those are the early complications. What I'm going to speak to you mostly about is the late complications, which is CLAD. CLAD stands for chronic lung allograft dysfunction. And that's a condition where the airways in the lungs become narrowed. Anything that damages a transplanted lung leads to CLAD. It's not that acute rejection is terrible and infections are treatable and okay. Actually, anything that damages the airways in a transplanted lung leads to what I think of as an abnormal healing response, where in my lungs, hopefully, if the airways are damaged, they'll heal normally. In a transplanted lung, they get a blitter of bronchiolitis with proliferation of smooth muscle and mesenchymal cells, causing narrowing of the airways. And you could perhaps try and visualize what that's like. If you think about taking the middle out of a kitchen roll and putting it over your mouth, you can easily breathe in and out through a big tube. If you then took the middle out of a biro pen and put that in your mouth and tried to run up and down a flight of stairs, breathing in and out through a narrow tube, the resistance to airflow is much, much greater, and the breathlessness that's experienced by having to breathe in and out of lungs with narrowed tubes is a huge burden to people, and causes deteriorating lung function, deteriorating quality of life, and ultimately is the commonest cause of death outside of the first year of lung transplants. All of these other complications are what I spend my time dealing with as well. So acute rejections, an early and late complication. Infections occur any time. Malignancy, particularly post-transplant lymphoproliferative disease, so lymphomas or skin cancers are the commonest cancers post-transplant. The other complications of the drugs are hypertension, renal impairment, diabetes, and hyperlipidemia. We have to deal with those. Airway stenosis is scarring at the surgical site, and if we do single lung transplants, then progression of native lung disease can become an issue. So CLAD is the major life-limiting complication in a lung transplant, and some of these things we can define and have defined treatments for. So neutrophilic airway dysfunction, we can treat with azithromycin. Acute cellular rejection, we can treat with augmented immunosuppression. Antibody-mediated rejection, the treatment is a bit less certain, to say the least, but we usually give augmented immunosuppression. Airway injuries can start to cause CLAD, and airway injuries can be from inhalation, both from gastroesophageal reflux, so overflow of gastroesophageal reflux into the airways. And these days we do LINX procedures for that, which is a ring of magnets around the gastroesophageal junction. Other inhalation injuries are with pollution. I'm not sure quite what to do about that. The Mayor of London thinks he's come up with a good answer with our new ultra low emission zone, but we'll see about that. Infections, I've said to you, are a major source of airway injury, and we spend a lot of time on infection prophylaxis and treatment. And then there's a phenomenon called restrictive allograft syndrome. Nobody quite knows what to do about that yet. But if these treatments don't work, what we're left with ultimately is a redo lung transplant. But to try and avoid that, the first treatment used to be lymphoid irradiation. At Harefield, we've now switched to using ECP provided by Theracos. ECP is a therapy where blood's withdrawn from the patient. The white blood cells are sensitized with a drug called Sorolens. The white blood cells are then exposed to ultraviolet light, and that alters the function of the white blood cells. I don't know quite how it does that, and nobody does yet, but we've got a study that's hoping to give us some of that information. The only thing we know that it does so far is increases the population of Tregs, the CD4, CD25 positive subtype of T lymphocytes. But it alters the function of white blood cells and dampens down the immune response to transplanted lungs. And we've started using this based on case series, largely from Germany and Vienna. And I think it's currently the best treatment for CLAD. That's somewhat a matter of opinion, but the study that we've got going on in the UK at the moment will hopefully give us answers both mechanistically about what ECP does and in a comparative study about the effectiveness as well. So just to finish off, effectiveness of lung transplants or success of lung transplants depends on appropriately selecting recipients who are bad enough to take the risk, but also well enough to benefit. It depends on available donors and of course surgical expertise. It depends on a proactive multidisciplinary medical team and long-term care. But also depends on innovation and research and the implementation of ECP in treating CLAD, which is the commonest life-limiting complication after lung transplants, I think is an advance. And the UK-based study that's currently ongoing hopefully will give us some more surety in that direction, as well as giving us scientific validation when we know how it works. I think Charlotte's on next. I'm sure she's going to give you a great view about what it's like to go through a lung transplant and treatment with ECP.
Thank you so much, Martin, and welcome, Charlotte. I think you do. Yes, there you are.
Hello.
Hello. Welcome to Stockholm.
Thank you very much.
We're looking forward to hear your story and your patient journey.
Wonderful. So, yeah, can I go ahead? Is that all right?
Yes, please.
Lovely. So, yeah, I'm here to talk about my transplant journey, and I'm currently going through ECP treatment. First of all, I will give you a little bit of an overview of me. I'm nearly 30 and I have cystic fibrosis. Due to recurrent chest infections and poor lung function and weight gain, I required a double lung transplant when I was just a teenager. I received my transplant at Harefield Hospital in October 2011, and July of this year I started ECP treatment after being diagnosed with CLAD. Just a couple of photos of me. I was born with CF and spent a large amount of my childhood in and out of hospital requiring IV antibiotics to try and keep my lung infections at bay. When I was 16, I was referred to Harefield for a transplant assessment, and I was placed on the transplant list and waited 10 months for my one and only call. I received my transplant in October 2011, which was 4 weeks before my 18th birthday. Having a transplant is tough. It's not only physically hard, but it's also mentally tough for both the patient and their family. I was very lucky to get my transplant when I did, as I was on constant IV antibiotics and my lungs were riddled with infections. There was no way that I could keep these at bay any longer. I was doing everything I could to keep myself as well as possible while on the transplant list, but this was just getting harder and harder. When I had my transplant, I knew that there were wishes and goals that I wanted to achieve. I knew that whatever my time was I was going to have, I would make the most of every single minute. 10 months after my transplant, I went back into education to get my A-levels. And from there, I moved away from home in Kent and moved to London and gained my undergraduate degree in television production and then went to work in TV for the Premier League. A few years later, I decided to go back and study for my master's in social work. And I now work full-time as a social worker, working with adults who have care and support needs. I've had the opportunity to travel parts of the world, including a cruise in Hawaii, where I zip-lined across the rainforest. I've parasailed in Greece, I've taught children English in Estonia, and I've been to Disney World in Florida. I've raised money for charity by doing a skydive across the Kent countryside, and I abseiled down the orbit in London. I've always aimed to not let my health control my life. I have been able to do so much of my time since I've had my transplant, and I've been very lucky with the opportunities that I've had. Transplant isn't easy, and in the back of your head, you are always thinking about rejection and infections and what that would mean for your life. However, what transplant gives you outweighs all the worries and concerns, and it truly is a gift. So my health had been pretty stable up until last year. My lung function had stayed relatively similar for many years until I caught COVID in the summer of 2022. Over the following months, my lung function suddenly dropped by about 0.5 litres, and I was treated for mild rejection and both bacterial and fungal infections. We expected my lung function to at least rise slightly with all this treatment. By March this year, it was clear that this wasn't going to be the case, and I started to get chest infections from colds and really struggled with ongoing sinus infections. I was then diagnosed with CLAD, and it was recommended that I start ECP treatment. So when ECP treatment was first mentioned to me, it was scary and daunting, going into the unknown and not knowing if I was going to work for me. But things moved pretty quick once it was agreed I was going to have ECP treatment. For me, the bit I dreaded the most was having a permanent line fitted. It had been over 10 years since I had one, and I didn't like the idea of the constant reminder of how my health had declined. I was also worried about how I was going to juggle having a full-time job on top of all the treatment. I had the line fitted in the beginning of July of this year and immediately started my first round of treatment. The line, as you expect, was sore and uncomfortable, but with regard to the treatment, the ECP nurses all put my mind at ease. To start, I had the treatment 2 days every 2 weeks for 3 rounds of treatment. And in between this, I was back to Harefield every week for dressing changes and flushes of my line. And this is also where they taught me to manage this myself. After 5 weeks of travelling up and down to Harefield, which is a 200-mile round trip for me each time, I was trained to manage my line, and treatment now is at 4 weekly. I've now had 5 rounds or 10 lots of treatment, and so far my lung function has remained stable. I've not had an infection since starting, and I manage my line around me, and I'm still able to work full time. Since starting the treatment, I've not had to change any of my plans, and I've been able to go away camping. I'm away again in November, and I'm off to Brussels in December. Although it is a big commitment, having the treatment and line, I've made sure it's fitted around my life and not taken over it. I do not have any side effects from the treatment, so I'm able to get back to work the following day. And for me, ECP has so far been a very positive experience, and I'm very grateful to be having the opportunity to even have it. Thank you.
Thank you so much, Charlotte. And if we also can have Martin online together.
Hi, yeah,
Yeah.
I'm back on sound but not on screen. Oh my God, there's my huge face on your screen again.
Well, I guess you know each other quite well. as a patient and a doctor right now. So
I think one of the privileges of my job is is getting involved in people's lives and knowing people long term. I personally find that much more satisfying than an acute medical speciality where patients are admitted, treated, and then never seen again. And I get to know lovely people like Charlotte.
how has the collaboration between you and Charlotte been? I mean, from both perspectives, Charlotte, how do you think about your treatment and the healthcare and the connection with your own physician in this way?
Yeah, I've been very lucky, you know, at Harefield. I've been there now. I've been going for about 13 years. And yeah, the team there are absolutely incredible. I honestly could not imagine trusting another team like I do them. And it's nice that, yeah, you walk around the hospital, you recognise faces, a very small hospital. So it is nice. It is much more personal than if you were somewhere else, especially with some of the big ones that we have in London. So yeah, I'm very, very lucky.
Because the patient journey differs a lot. We have heard that today here in the Transplantation Forum and also in other occasions that you can discover a lot of errors along the way, actually, between the physicians and the patients because the communication is not well enough. But you were talking about this special treatment now, and Martin, you as a physician and have met also many other patients than Charlotte. How do you think about how to tell about the new treatment and how it will be accepted?
Yeah, we've been providing ECP treatment since I think 2017 at Harefield, and I think Charlotte raised some good points about ECP as treatment. Charlotte, you mentioned having a permanent line inserted and the emotional aspects of that. I think about half of the people that we treat need a permanent indwelling venous access because, as I mentioned, the treatment involves removing blood, treating it, and returning blood. So venous access is part of the deal. Some people can just have a cannula put in each time they need treatment, and other people who've had many more medical interventions and whose veins have suffered a bit need an indwelling catheter, and that's a downside. Charlotte also mentioned the treatment frequency, which is a heavy burden of attendance at the hospital to undergo ECP. It's not a treatment that you turn up and have and it's done and you go away again as a finished episode. It's an ongoing treatment. But I think those downsides are important to put into a context of the other treatments that are available and what happens if those treatments aren't provided. So the best alternative treatment before ECP was available, it was a treatment called lymphoid irradiation, which sounds pretty horrible. It's not as bad as it sounds, but it's not pleasant either. And the reason we switched to ECP as first-line treatment rather than lymphoid irradiation is because of what Charlotte said about a lack of side effects from ECP treatment. Lymphoid irradiation, although it's well tolerated, takes a couple of weeks to have radiation therapy. There's a period of neutropenia almost inevitably afterwards. And because X-rays are shone at the major lymph nodes in the chest and the abdomen, it inevitably catches a bit of the esophagus, and there's some nausea and esophagitis associated with lymphoid irradiation. And people sometimes feel a little bit tired afterwards as well, and those symptoms can go on for a number of weeks. And ECP is relatively devoid of side effects for most people, consistent with Charlotte's experience. And also, as well as considering the negatives, it's obviously important to consider the positives. And I think Charlotte very eloquently highlighted the improvements in her quality of life, her maintained functioning, doing amazing stuff, Charlotte. I'd quite like to do a load of those things myself. So the difference for Charlotte with recurrent infections and deteriorating lung function before ECP treatment, but then ECP allowing us to perhaps give a few less immunosuppressive drugs, have a well-tolerated treatment, less infective complications with maintained lung function, is as Charlotte describes it. It's a change for the better.
Sounds good. And Charlotte, if I may ask, did you have any choices for your treatment? I mean, this sounds very good with less side effects and everything, but did you have any options to choose in between?
So really, like Dr. Carby said, we tend to look straight at ECP over TLI now. And to be quite honest, for me, the fact that that's what the doctors at Harefield recommended, that's what I would take. I was never going to be someone that would turn down the opportunity to try and stable out my lung function. I want to carry on living as well of a normal life as I possibly can. So to be honest, I trust whatever Harefield recommend, and I will take anything that they will offer.
So you never question?
No. No, because for me, don't get me wrong, I'll ask questions about things like the treatment and stuff, but, the fact that actually they had said I'd got PLAD and, without a treatment that could potentially stop my lung function, it possibly would have kept declining. So for me, that wasn't something I wasn't willing to go down without a fight, and the chance to have the treatment came up. So yeah, I didn't say no to it at all.
We just had a seminar here that when we were talking about, living your life when you have had a transplant, and really to take all opportunities to really live when you have the chance now. I think it's quite gratifying for you as a doctor, Martin, to really see people and patients who are living their life again after a successful treatment.
Absolutely. And we never discharge somebody from long-term follow-up after a lung transplant. I mean, complications sadly can occur anytime. So once somebody's had a lung transplant at Harefield, they're always part of the family, whether they want to be or not. But it's a bit difficult when the lung function starts to decline. When, as a physician, I've identified all of the things that I can, both risk factors like gastroesophageal reflux, and proactively treated those. We've identified and treated all of the infectious elements that come along with immunosuppression. We've done as much as we can with moderating immunosuppressive drugs. And when lung function starts to go down, it's pretty sad, because it's sort of the beginning of the end, really, unless somebody's suitable for a redo transplant, which very few people are because of the ravages of drugs and infections over time with the first transplant. So there's a real need to have effective treatments for CLAD, and yeah, I'm happy to say that Charlotte's responding very well. That's not the case for everybody, but that's always been the way with lung transplants. But it's nice to have a treatment that I can offer to people now that doesn't come along with a whole load of downsides to it, and the worst bits are the ones that Charlotte has described, which are the burden of travel to the hospital, and for some people an IV line. Charlotte didn't mention the sunglasses, but of course being sensitised to sunlight isn't too much of a problem in the UK, but we still advise people to wear some sunglasses for 24 hours after being UV sensitised with Sorolace. But it's nice to have a treatment that doesn't require a long hospital admission. It doesn't come along with a whole load of side effects, and we can have a sort of reasonable degree of surety that we're doing the most that we can to maintain lung function. And look, it stabilises a majority of people. So there's a real need for treatments for CLAD. What I really hope that we can do with the study in the UK is to prove beyond all doubt that it works in a randomised study, which, to my mind, case series have already done. But in the medical world, a randomised case-controlled study is the gold standard. So we're doing that. But then also it's important to know a little bit more about how ECP actually does what it does, so that we can target the treatment to the people most likely to benefit, maybe even at an earlier stage. It may have uses, who knows, before lung function even starts to decline. But once we know what it does and how it works, we'll be in a much better position to judge that.
Thank you so much, Martin. And to close up this interesting session, Charlotte, what are your visions for the future?
Go on more holidays. Probably do something that is a little bit crazy. Like I jumped out of a plane, so that one's done. So yeah, I will have to come up with a different idea. Quite like the idea of maybe doing a wing walk or something, but we'll see.
I wish you all success in life, Charlotte, and thank you so much to both of you, and thank you, Terracos, for sponsoring this seminar. Thank you so much.
Thank you.
Thanks for inviting me. Enjoy the rest of your day.